Hello, this is Dr. Marty Lustig, Senior Vice President with NextGen Healthcare and a Principal with NextGen Advisors. Welcome to our weekly podcast, focusing on significant issues in healthcare. I'm joined again today by my colleagues, Graham Brown and Dr. Betty Rabinowitz. Welcome to both of you.
Morning, Marty.
With two of the most common news stories of late being the pandemic and mass shootings, we thought it might be a good thing to sort of combine these topics by discussing violence as a public health issue. Dr. Gary Slutkin, an infectious disease specialist and epidemiologist, has put forth a theory that violence, not unlike COVID-19, is actually a contagious disease, and that by applying individual and public health interventions, we can reduce the incidence, prevalence, and spread. You both had a chance to review Dr. Slutkin's arguments. Graham, did you find them convincing?
Interesting question, Marty. Overall, yes, I think I did. Violence shows, not only the characteristics of infectious disease in populations, but also the characteristics and key concepts of an infectious disease in an individual. And what Dr. Slutkin outlines is the shift in our understanding in terms of, how violence and the details, the rationale as to why there's such a strong parallel between how we view violence and how we view disease. And I think he makes a compelling argument in that regard. He's looking in some aspects at the great plagues that we had in history, how science evolved to consider and understand infectious disease as we understood microbes and its course in population, and looks at how if we treat violence as we would an epidemic of contagious disease, that several studies of interventions have demonstrated some positive effects. So there's some compelling ideas in this concept, and using an epidemiological model is an interesting approach to this topic.
Betty, what was your reaction?
I found the metaphor compelling. So it was very interesting to see parallels of graphic descriptions. He drew graphs out of pandemics of the past and compared it to, for example, the civil war in Rwanda. And you could see that the pattern of violence and the spread of it followed very closely the pandemic of the infectious agent. I must say, though, that in a certain way, my sense is that human behavior as a whole is probably highly learned, highly contagious, if you will. I think kindness is similar probably, and positive human behavior similarly spreads and is propagated in similar ways. So I don't think violence is unique to that. He, for example, speaks about herd immunity. We've been talking about herd immunity quite a bit, which are the forces that allow a community to be resistant to the spread of violence because of education or religious beliefs or the strength of the family or the strength of the community. So some very intriguing, thought-provoking concepts, but I'm not sure how to operationalize it or whether it explains the type of lone wolf violence that we have been struggling with over the last few years of mentally ill individuals having access to firearms and propagating these horrendous mass violent events. And I'm not sure how that kind of uses this model.
Interesting. One of the things you both touched on was sort of the value of the epidemiologic concepts. And when you look specifically at things like susceptibility, exposure, incubation periods, the clinical spectrum of a disease, so to speak, and talking about cures and relapses and chronic illness, how do you see those concepts translating into violence in terms of their potential practical value? Betty, you want to start on that one?
I think that the practical value is first and foremost that it's preventable, that it isn't inevitable that we live with violence or that we accept violence or that violence is part of the human nature, where there's some theories put forward that it's in our It's in our makeup to live, and that through generations there has always been wars, there's always been strife and violence per human against other human. So that's very valuable, that it is something like disease that we can take measures to mitigate or reduce or solve. I am not sure where, I think susceptibility as it relates to poverty, mental illness, lack of privilege, lack of education, poor environment, the breakdown of the family unit. Those are all probably in this model what makes you susceptible. I'm not sure how the infectious disease model helps you solve those. Those are deep societal issues, and I wish it was as clean as easy as cleaning the surfaces or applying Clorox to the water supply, or whatever the issue is. So I think that translating to a practical approach is where this gets a bit rickety for me.
Graham, what are your thoughts on that?
Yeah, I see where Betty's coming from on this. I think I have a slightly different perspective in that, I think the concepts apply here to me. There's been this kind of long-standing separation of the body and the mind, which doesn't really make sense in terms of how we treat individuals. And what Dr. Slutkin is proposing or purporting here is that the pathogenesis of violence in individuals replicates or mirrors all aspects of the same course of a serious viral infection. And I think he does a compelling argument of laying out how those concepts tie together. What I hear in Betty's comment, though, is that, really the exposure to violence at an early age or repeated exposure may position somebody to be more susceptible to, incubate violence in their own life, be a carrier of that, and ultimately show signs and symptoms themselves of violent behavior later in their life. I think that, to Betty's point, there's a number of other factors that are indeed influencing somebody's propensity to become violent or to be exposed to that violence. And we do need to address those in more societal ways. But I think there's a really helpful methodology here to understand the course of the disease, if you are willing to make that leap and consider violence as a disease. And that in that context, there's a number of parallels that we can really look at interventions that, outside of this article, which really looks at interventions within gangs and whether they can intervene at the right point where violence is occurring to prevent future violence. I think it gives a lot of different opportunities for interventions to use a common framework to understand their efficacy and whether those interventions actually are effective or not.
So along those lines, Dr. Slutkin, as you both know from reading the article, created an organization called Cure Violence, where he actually they have these what they call interrupters, where they try to go in, identify index cases, hotspots, and have staff that actually go out and work in the community. Interestingly, one of the things they realized is that in order to be effective in the interventions, they have to actually be members of those communities where the violence is occurring and have trusting relationships with the people that they're working with. So the early results of that work actually in the articles looked somewhat promising. Graham, what did you think of that as a specific intervention?
I agree, Marty. I do think the early results did look promising. I think, the interventions were tested in a variety of different communities, and they had slightly different models in terms of that violence intervener, the other support staff, how ingratiated, as it were, the individuals who were the violence interveners were in the community, and how connected the program was to other community supports. And I think that variability in the program design meant that there were really different findings in the assessments that were undertaken. So the conclusions in the aggregate across the different cities and their impact on neighborhoods wasn't really easy to compare necessarily. But some of the things they did find was the overall drop in violence, specifically incidents of gun violence, as well as communities understanding that there was an intervention program in place and that there was some sense of comfort and belief that such a program could work. was helpful to see and hopeful to see. I don't know that the evaluation design necessarily developed the results that would have made a more strong commitment to this approach.
Betty?
What's interesting to me is to question the comparison across different societies and their propensity for violence. And clearly the United States is standing out of late in the level of violence, its consequences, and the terrible human life, the price in human life that we're paying for this violence. And I wonder how, if we compare this to, for example, the Japanese society, or if we compare this to Western European societies where there's a lot less gun violence and death related to it, or New Zealand or Australia where there's different numbers, how that difference would be explained with this theory.
I'm sure Dr. Slutkin would say that they have in community, whether it's communities or societies, where they've provided the kind of supports in the community that make them less susceptible to violence, that it's easy to extend the logic and use that vocabulary to describe what's going on, for example, in Japan.
The question is there an underlying susceptibility that has to do with other factors? Do laws matter? So, for example, the example, I think it was in New Zealand, where they had a rash of gun violence, but changed fundamentally access to high-velocity weapons, and they saw a very significant drop. My sense is without changing any of the societal forces. So
right.
I'm struck by how nuanced and complex this is, and how it doesn't very easily lend itself to this very linear cause and effect intervention model that's being suggested, even though I find parts of it incredibly compelling. It was a fascinating read, but
I think to your point on the complexity of it, Betty, a lot of the discussions in the literature of this work that have come out since the original study in Chicago and others that have replicated the results have spoken to the complexity of the issue and the difficulty of assigning even the improvements that were measured to the interventions that occurred because of all the other forces at work. And it's almost impossible to create good control groups for these kinds of studies, and on and on. So it really is, I think, fascinating. And it kind of begs the question as to, you used the word earlier about this being a powerful metaphor, but Dr. Slutkin clearly argues that not that this is a metaphor, but this is actually, violence is a disease. It's a contagious disease, just like a viral illness is, and that we need to learn to think about it that way. What I find most attractive about that argument is the sort of destigmatization of the issue and the attempt to bring the scientific method to understanding and impacting it. But the logical conclusion of his argument is that someday we're going to have a brain pill that will get rid of violence somehow. And do you really believe that, or do you just still see this as a powerful metaphor?
I personally see it as, I don't believe that. I don't. I see it as a very powerful, useful metaphor to start the conversation, to assign the resources, to get the attention, and depoliticize it in some way. We are not, note, we haven't spoken about guns. In this podcast, it's not about. This is really useful because it's a construct that everyone can discuss and participate in without pushing deeply embedded buttons. I'm, for example, intrigued by what would happen if you took out of this entire conversation of violence in our society drugs. If drugs weren't an addiction, weren't in the midst, what would it look like? if you took poverty and lack of opportunity out of it, what would it look like? The author would probably say that's what I'm talking about. You're removing susceptibility or accelerators of infection. But it is very complicated, layered.
It is. It's very complicated indeed. I agree with Betty. I don't think we can solve every disease with a magic pill, and certainly violence isn't one that seems susceptible to a magic pill or a vaccine. But I think what we can do is interrupt the course of disease at every stage of its development. And so if you go with the metaphor that violence can be associated conceptually with a contagious disease, then we can look at prevention and particularly preventing exposure to violence. To Betty's point, if you think about removing drugs from these scenarios, poverty, etc., that's gonna have a cascading effect. But think about, one of the points that Dr. Slutkin makes is, what about individual sexual violence that children may experience? And what does that correlate to their likelihood to become perpetuators of sexual violence when they become adults or later on? So preventing exposure to violence and recognizing the role that clustering of violence has on communities, when consistently certain zip codes have a higher level of violence than others. So really, therefore, increasing the number of individuals that are therefore susceptible to violence in the future. I think it really calls for instituting restorative justice programs during the incubation period, after individuals have been exposed to violence, but before they develop the symptoms or behaviors that further perpetuate that cycle. One of the things that the author speaks to is recognizing that the syndromes of violence can be understood as different types of violence. So violence to the general public, community violence, intimate partner violence, child abuse, and suicide. If we think about all of those as different types of violence, then we can look at them as kind of different versions of the same disease that ultimately can derive from the same cause, but show up under very different circumstances. And so that really gets to Betty's point. What are those other circumstances that are going to, after someone's been exposed, make them more susceptible to being a perpetrator later in life? Or to be, if they don't break that cycle and get out of that environment, will they continue to be exposed to violence in a way that just makes their life more and more difficult to live and their situation more troublesome and higher risk?
In many ways, this reminds me of work that I've been involved with locally in my community on adverse childhood experiences and what interventions can we do that build resilience in children and that focus on prevention to reduce the number of these occurring. It's kind of similar to what you said. So, Graham, you already anticipated my last question, so I'll just ask Betty if you want to comment as well on sort of where you see the value of these epidemiologic concepts in approaching this issue going forward.
I think that any discussion that brings this topic to the fore, that allows us to begin to dedicate societal resources at all levels, political, budgetary, school, education, the family, communities, is highly valuable, should be welcomed. I found this incredibly thought-provoking. It's been on my mind since I read the article. Part of me is kind of resistant to it, but it is compelling nonetheless. I really invite, we will put the reference to this article at the bottom of our podcast on the website. I recommend people read it. I think it's a very elegant piece of work, but I think that the problem is going to this one is going to be with us for a while. We have a lot of work to do. I wish it was this simple.
Don't we all? Yes, thank you. So I do want to thank you, Dr. Betty Rabinowitz and Graham Brown, for joining me today, and thank our listeners for tuning in. Don't forget that by subscribing to our podcast, you'll get a weekly reminder of each new episode. This is Dr. Marty Lustig with NextGen Healthcare. Thanks and have a great day.